Okay, so we're back again to finish up our review. And now that you know a little bit more about serotonin and what it does, I want to go back and visit the medications for migraine headaches. And migraine headaches are caused from vasodilation in the brain. So if we give a serotonin agonist, it causes vasoconstriction. And this vasoconstriction relieves the symptoms of the migraine. However, anytime we cause vasoconstriction, it also has an effect on the heart. And this is what causes the chest pressure and heaviness. So that is the main safety alert for the serotonin agonists that are used to treat migraine headaches. It's the chest pressure, heaviness, and the cardiac effects. So there's also some CNS effects, of course, and they are the tingling and vertigo, and that's because of the CNS stimulation. So our interventions would include monitoring vital signs. This medication can also come in a nasal spray. And then, of course, client instructions go back to the chest pressure, and we want them to notify their provider because it can cause a myocardial infarction. So we also use caution with MAOIs, and we know why. And then, like the other serotonin, other medications that increase serotonin, this can also result in serotonin syndrome. And then I want to visit one more thing from our previous lecture before we move on to our new content, and that is the benzodiazepines. No one has asked this question yet, but just in case, when we talk about the romazicon, if you remember, I said we would only use this in patients as a reversal of benzodiazepine overdose. We would only use this in patients that we know have not been on benzodiazepines for long term. And I gave the example of, a pediatric patient that may have gotten into their caregiver's medication and had an accidental overdose. We could reverse that with using the flumazenil. And then I said that if a patient's been taking benzodiazepines long term, or, let's say it's an adult patient that we know has substance abuse disorder and they have overdosed and we don't truly know how long they've been on that medication, in those cases we would not give flumazenil because we would not want them to have the withdrawal symptom of status epilepticus or uncontrolled seizures. So you may have asked yourself, okay, well, what do we do in those situations for a patient that's been on benzodiazepines long term and they've had a respiratory arrest or they've had, an overdose of that benzodiazepine? In those cases, we would just do supportive care. So we would establish an airway, monitor vital signs. If they're hypotensive, we may give them fluids or medications to increase their blood pressure. Things like that. So it would be supportive care. Okay, and now we will move forward to our new content. And our new content starts with drugs that are used for bipolar disorder. And the first prototype drug is lithium. And lithium is also a very toxic medication. Okay, so when we're thinking about NCLEX and being safe for practice, we want to make sure we know the highly toxic drugs, right, to make sure that we're safe. And lithium is one of those really highly toxic drugs, and that is because lithium also works on the salt content of the body. Its mechanism of action in treating bipolar disorder isn't completely understood. However, it's thought that the way it acts with salt has an effect on the catecholamines, which means norepinephrine, epinephrine, serotonin, and things like that. So it works on salt to change those neurotransmitters in the brain to help control acute manic episodes in bipolar disorder. It can also be used as a maintenance drug, but again, because it's so toxic, we really don't see it a whole lot. Actually, when I was in high school, I had my very close friend, her sister, who was just a couple years older than us. She actually passed away from lithium toxicity. And we were all young, and it was completely a shock to everyone, of course. And when you're on lithium, when a patient takes lithium, because it's so toxic and it has that therapeutic, a narrow therapeutic index, or that narrow therapeutic range, we have to have lithium levels monitored. So patients are required to get their blood drawn to monitor their lithium level to make sure that we don't tip over into toxicity and toxic effects. In this case, my friend's sister was not compliant with that, and she ended up becoming toxic, and it was actually what took her life at a very young age. So lithium stands out to me personally, but again, I can tell you just in your professional life as a nurse, you're not going to see a lot of patients on this, but if you do, you want to pay very close attention to their lithium levels and making sure the patient's being compliant with getting their lab work done. Okay, so lithium can cause GI effects and muscle weakness, drowsiness, headache, and confusion. This polyuria, and that again is because of the way lithium acts in the body and the way it acts with sodium. Okay, so sodium and water have a direct relationship. Tremors. This is also a side effect, but it's a major concern for a sign of toxicity. Lithium can also damage the thyroid and cause hypothyroidism, which again is a unique side effect. The toxicity, this is also the safety alert, is due to the narrow therapeutic range, GI symptoms, muscle weakness, the tremor, and the tremor can progress to seizures. And I'm sure you've noticed by now, but that's a major concern in all of these medications that cross the blood-brain barrier and have their effects on the brain. And if we can't control the seizures, then that can lead to death. Interventions include making sure that you are monitoring their lithium levels, monitor their intake and output, their electrolyte balance, because again it has an effect on salt. This one here mentions the lithium level, and it gives you a value. It says that it should be below 1. And then monitor the sodium levels, and it says that low sodium can cause toxicity, and that is because lithium is a salt. So if the body is already low on salt, what it will do is it will hold on to lithium because the body recognizes it as a salt. So it says, okay, my salt content is low, so I'm going to hold on to this lithium and not excrete it. And lithium is just a synthetic salt that has kind of tricked the body. And then what happens is because lithium's not being excreted, we now have toxic levels. So we always want to look at their sodium level, make sure that they're within normal limits before we give lithium. And then of course it can be hard on the kidneys as well. Anytime that there is a sustained release tablet, we always educate the patient not to chew or crush that medication. So that is applied to, it doesn't matter what the medication is, if it's extended release or sustained release, the education is always to swallow the medication whole and not to chew it up. Anytime a medication can cause drowsiness, we give them drowsiness precautions, tell them not to perform any hazardous tasks. And then again, with lithium specifically, we instruct the client and educate them to make sure that they're drinking plenty of fluids, again, because lithium is a salt and it could cause a water imbalance in the patient. And then, of course, we want to educate them for signs of hypothyroidism, like the goiter in the neck, and because lithium is toxic to the thyroid. And then we want to instruct the client to consume adequate amounts of food containing sodium or salt. And again, that's because we do not want them to become hyponatremic, because hyponatremia can lead to lithium toxicity. This medication is also teratogenic, and I think almost every medication we've reviewed so far in this section are teratogenic medications. And then the other thing too is that it can cause cardiac disorders. Again, anytime we change sodium, we also change the way that the heart works. Okay, so anytime we're messing with sodium, we always need to be concerned for possible cardiac effects. So if we flip back to ATI, then we see the other drug class that's used to treat bipolar disorders are some of the anti-epileptic drugs can be used, and we've already covered these medications in the Neuro Part 1 review. So just review that information again, and you can see down here which specific medications are used to treat bipolar disorder. So make sure you're reviewing those safety alerts and nursing interventions as well. Okay, so next up are the drugs that treat schizophrenia. And at this point, you've probably learned about these pathologies in your concepts nursing class. So schizophrenia is a psychosis that can result in hallucinations, paranoia, and things like that. So it can be life-altering, and the medications used to treat it also act on a number of different receptor sites in the brain. Okay, so these antipsychotics medications have a wide array of side effects because they act on lots of different receptor sites. They're not as selective as the antidepressants, anti-anxiety medications. They are acting on lots of different neurotransmitters, lots of different receptor sites in the brain. So chlorpromazine is your prototype drug. It is Thorazine, the brand name is Thorazine, but also haloperidol or the brand name Haldol. And if we flip back over to ATI, you can see the haloperidol here, and Haldol is the brand name. That's also a very commonly used one. So even though ATI lists Thorazine as your prototype, Haldol is also very common, and I want you guys to be aware of that one too. Okay, so the conventional antipsychotics are used to suppress the symptoms of schizophrenia. It can also help with treat the manic phase of bipolar disorder. It relieves nausea and vomiting, and if you guys remember, Phenergan, also called promethazine, is the generic. It's not used as much anymore, but it used to be used to treat nausea and vomiting. And with that medication, there was a lot of CNS depression as patients become very drowsy. And it's not used as much anymore, but it was just one of these antipsychotic drugs that actually showed to have a good effect on treating nausea and vomiting, and that was its... Okay, sorry about that. I had a little interruption from my sweet little 9-year-old. But anyways, back to promethazine, also known as Phenergan. It was used specifically just only to treat nausea and vomiting. It's not used as much anymore, but all of these antipsychotics, the place that they work in the brain, also can suppress this nausea and vomiting. The other odd thing that it's used for is intractable hiccups, but again, we are focusing more on the antipsychotic effects. Okay, major adverse drug reactions. And in this, remember, we are suppressing dopamine mostly. So when we suppress dopamine, we know that it is what inhibits muscle movement. So when we suppress it even more, we can have too much muscle movement. Okay, so we can have the Parkinson-like symptoms. And this part's actually very important. Okay, so anytime you think about antipsychotic drugs, you need to be thinking that these things can happen. Too much muscle movement. And it can start with the akathisia, which occurs within the first 2 months of therapy. It can progress into Parkinson-like symptoms, which also can occur within the first month of therapy. Acute dystonia, and this is very serious. This occurs hours to days following the first dose, and you need to know what akathisias are, what dystonia is, and I think I have a picture of dystonia. Okay, and here's our picture. I just found this on the internet, and you can see how it makes the muscles really rigid, and this can become permanent. Okay, so it's a big deal adverse effect, and you pick up on it by noticing when they start to have a little bit of tremor, a little bit of odd muscle movement, and if we can intervene when it's early, then it won't progress into what we're really truly concerned about, and that is this tardive dyskinesia. And this occurs months to years after therapy begins. And tardive dyskinesia is permanent. It's something we can't reverse. But if we can catch it here in the earlier stages, then we can reverse it. So it's super important that you educate the patient to this so that they can report it to their doctor. And they can either stop the medication or give other medications to help with the symptoms and decrease the symptoms. And just because it's so serious, I want to actually show you a video of what tardive dyskinesia looks like. Okay, and I just found this video just on a search. I just typed in tardive dyskinesia and found this one. And remember, this is a permanent, irreversible side effect. Okay, so once it's gone too far, this cannot be reversed. And imagine being the patient having to live with this. Okay, so you are the patient advocate. It's your responsibility to educate these patients so that they know to report any signs and symptoms of abnormal muscle movements to their doctor so that they can treat them or so they can stop the medication and start a different one so that the patient does not end up with this lifelong. Okay, and this patient, if I would have the sound on, you would know that she is completely alert and oriented, no effect on her cognition, just the muscle movements. Okay, so she's completely aware of all of this, and this is her life. Okay. Okay, so how do we treat tardive dyskinesia? Or actually, tardive dyskinesia is irreversible. So how do we treat early signs of the akathisia or Parkinson's-like symptoms or acute dystonia? We can treat them with anticholinergic drugs or for example, diphenhydramine, which is Benadryl, and Benadryl can help reverse the effects of the dystonia. Okay, so I hope that you are going to let that, if you don't learn anything else about antipsychotics, that needs to be the one thing that you really know about them. Again, because you want to intervene before it completely changes the patient's life. Okay? So remember that antipsychotics work on an array of receptors in the brain, all kinds of different receptors, and one of their effects can be an anticholinergic effect, and that causes the dry mouth, constipation, urinary retention, blurred vision, and tachycardia. This medication can also suppress their sexual drive and cause erectile dysfunction. Again, you need to educate the patient on that to help increase compliance and so that they understand that it is a result of the medication so that they don't think that something's wrong with them. It can cause severe cardiac dysrhythmias, and then another big deal one, major one, because it can be lethal, is this neuroleptic malignant syndrome. Okay, so this is when there's high fevers, there's muscle rigidity, vital sign instability, loss of consciousness, and this is more common with the Howdall. If the patients happen to have signs and symptoms that are concerning for tardive dyskinesia, they can be switched to an atypical antipsychotic, which we'll review in a few minutes. We went over all of this here. Remember when we went over dantrolene from our first CNS lecture from the part 1 from last week? It is what is used to treat this neuroleptic malignant syndrome, which I think we referred to it as malignant hypertension in the previous lecture from last week. So dantrolene is like a muscle relaxant to help reduce the rigidity. Another important nursing intervention is to keep the client recumbent for 30 minutes after IM or IV dose due to the possible hypotension. So you want to monitor these patients. Let's say you're working in the ER and you have someone come in, in like a psychosis, and we give them one of these medications. You monitor them afterwards. We went over all of this too. It all relates back to the safety alerts of the tardive dyskinesia, dystonia, akathisia, and the neuroleptic malignant syndrome. And reporting of a sudden fever is major, important topic to discuss with the client, teach them, because again, we are very concerned for this neuroleptic malignant syndrome. Contraindications again with pregnancy and lactation. Okay, so I'm going to switch back to ATI for just a second to show you that we do have atypical antipsychotics. They work like the conventional antipsychotics, however, they have a major significant difference, and that is the occurrence of the adverse drug reactions. Okay, so the atypical antipsychotics are less likely to cause the extrapyramidal effects. And the extrapyramidal effects are the things like the muscle movement disorders that we talked about. And the extrapyramidal is just a part of the brain that's responsible for that. And then it's abbreviated EPS. So anytime you see extrapyramidal, it means the same thing as those muscle movement disorders like akathisia, Parkinson's-like syndrome, or symptoms, and tardive dyskinesia. Okay, so the prototype drugs, I think risperidone is our main prototype drug. It's the one that there's an ATI drug card on. For the atypical or second generation antipsychotics, but there's a lot of other common ones that we see in practice that you should be aware of. So whether you're using the templates or the drug cards, I would go ahead and write these medications out on the drug card or in the template so that you can identify that they are also atypical antipsychotics, because Geodon is one we use a lot. We see it a lot too, as well as Clozaril, Abilify, Zyprexa, Seroquel. I mean, these are used often. Okay, so if we get back to the drug card, it is on risperidone, but again, like I said, I would write the other generic names out here, or if you're using the template, I would write it there. These atypical antipsychotics can treat both the positive and negative symptoms of schizophrenia, and that's not something we're going to discuss in this class because I know that you'll identify it in your concepts class. But basically it treats both types of symptoms with schizophrenia. It can treat bipolar disorder and also irritability in clients who have autism. They cross the blood-brain barrier, and they cause central nervous system depression. And it still has this extrapyramidal effect because it is suppressing dopamine. But the atypicals, unlike the conventional antipsychotics, the atypicals suppress more serotonin than it does dopamine. And that's why it can still have these extrapyramidal effects, but they're not as seen as often as with the conventional antipsychotics because the conventional antipsychotics are suppressing way more dopamine. And dopamine is what's used to inhibit our muscle movement. And when it's completely suppressed, we have overactive muscles. So again, you still see the extrapyramidal effects. You guys now know how serious they can be, but they're less often seen in the atypicals than in the conventional antipsychotics. The other thing that is unique to the atypical antipsychotics is the weight gain and the onset of new diabetes or worsening or existing diabetes and cholesterol levels. So this is all something you would want to teach patients to monitor their weight, report any significant weight gain, and then also you assess them for either new onset diabetes or worsening diabetes. Everything else goes with what we've already mentioned in the conventional antipsychotics and how you monitor for dystonia, for CNS depression, and how you treat those things once you identify them. The only thing that's new here is the monitor weight, and blood glucose, and their cholesterol levels. Drowsiness precautions identified here, and client education around those things such as diabetes, especially the extrapyramidal effects. Contraindications, this prolonged QT interval, it's definitely important, but we'll discuss more about what that means when we get to cardiology. Here's another issue with lactation. And then it can also have an interaction with some of the other anti-Parkinson's drugs. So if a patient has Parkinson's, then we want to tell them to monitor their symptoms as well and to report any changes. Okay, and then we have one more area under neuro, but I think we've covered enough, honestly. There's a lot to know with these medications. Even though a lot of adverse effects are similar, it's still a lot to keep in our mind. So I'm going to go over the drug therapy for glaucoma on a different day. Okay? And don't forget, as always, to do your case study. And all of these looks like it goes around glaucoma. So I still think it's best to go over the glaucoma drugs on a different day. Because I really feel like the priority, even though the case study centers around it, I really feel like the priority information are the safety concerns for the drug therapy for schizophrenia, bipolar disorder, depression, and anxiety. And I want you guys to get those things first, and then we'll move into glaucoma later. Okay? And then don't forget about your activities. And to take notes on any of the things that you get wrong with the rationales. And maybe we'll just, instead of having a case study, Reflection, let's just do the reflection on the activities. Okay, so just let me know in these notes how you did on these practice questions here, and just maybe write some notes around the things that you got wrong, and just review that. So we'll do that this week instead. Instead of doing the case study reflection, we're going to do an activities reflection. Okay, so let me know if you guys have any questions, concerns, feedback, anything that could be helpful to you. Please let me know.